For the next few minutes, I want to share some thoughts about prevention and care strategies for high-risk populations in Puerto Rico. I am using high-risk likely, that was a suggested title. I think Amanda already problematized the way we are using those terms. So with this presentation, I'm aiming three goals. First, I will share recent research findings that looks like opportunities to improve HIV prevention and care services in Puerto Rico. Most of the research that I am going to present has been implemented by our team at the University of Puerto Rico. You might notice that in our slide deck we have three logos. The SEX team is the research team at the University of Puerto Rico School of Public Health that we started about 8 years ago. Now Dr. Suhey Malave, Dr. Melissa Marsan are collaborating from the team at the University of Puerto Rico. I recently moved to the Milken Institute School of Public Health at the George Washington University, and I'm building collaborations between the two institutions, and we are doing research together, so we will introduce some of the research activities that we are starting to do together. So the second goal is to share some initiative, some projects that we are developing to address some of the issues that we have identified through formative research. And third, I have one slide with very specific recommendations for future research and implementation for HIV prevention and care services here in Puerto Rico. I want to start by clarifying my take on HIV data and how I use HIV-related information and how we conduct HIV research. We use a socio-epidemiologic lens to look at risks and to look at how we create context under which people can be at risk. We are not only looking at behaviors or very specific individual factors that are associated with risk for HIV. And this is a model that basically illustrates that we have many layers of factors that influence what causes risk and therefore HIV infections. And we work in the intersection of these layers. So for example, how we provide services in the community for people who are affected by a structural factor like prisons. That's an example that we just discussed before lunch. And this is not rocket science. We've been discussing about social determinants of health with different terms for actually almost a century. But more recently is a term that has been embraced by local, federal, and global organizations. Even the CDC have made a report on social determinants of health among people diagnosed with HIV, including Puerto Rico. And what we know is that there are structural factors like economic resources that influence the likelihood of a person to get infected with HIV. That doesn't mean that the poorer the person is, the likelihood increases. It's actually about the neighborhood and the context, because poor people or people that have different experience with resources are not inherently at risk of HIV infection. It's the conditions around poverty that increases the vulnerability. Similarly with education, and I think that's a very interesting point to connect previous discussions in which we can evidence that it doesn't matter if the person is well educated or uneducated. Really, it's the context of where education happens, because increases the risks. Health literacy is not the same as an academic degree, right? And what we know is that the lower education in the neighborhood increases the risk factor for HIV infection. And it's not a sole factor, it's because it's also connected with economic resources and economic opportunities that comes with education, okay? This graph has been shown by several presenters, so I'm not going to get into details. I think that we have good news to share, and is that we have made important changes in the HIV epidemic in Puerto Rico. For example, we are diagnosing more people with early infection rather than diagnosing more people with AIDS. mortality rate has decreased significantly. But still, as of July this year, we have nearly 20,000 people, over 20,000 people living with HIV in Puerto Rico. We also have nearly 700 children that have been diagnosed with HIV. Now I'm sharing some trends in terms of incidence. I know that some of my colleagues have presented incidence data already, but on purpose, I'm presenting kind of old data. This is from 2002 to 2013, and the purpose of that is because here, around 2008, we saw a shift in the epidemic. Look at how our epidemic was in 2002, mostly driven by injecting drug use and heterosexual transmission. Based on the data that we have from surveillance, incidence among injecting drug users have been going down. But look at the yellow dots. Those are incidence among MSM. And if we take a closer look at incidence data, this is from 2010 to 2016. Now we are dealing mostly with a sexually transmitted epidemic. And why is that important? Well, the resources that we need to prevent and to provide services for a sexually transmitted epidemic are different than one that is driven by injecting drug use. So we need to talk about sex. And we need to feel comfortable about talking about sex, sexual practices, sexual pleasure, sexuality education. Otherwise, we are doing an incomplete service in prevention services. And we need to address the needs of sexual minority populations that are at increased risk for infection and are falling behind in care. This was also shared earlier. I just want to highlight that it's not only a matter of age. So yes, most of the new cases are happening in relatively young populations, but even among MSM, the youngest, the higher the amount of cases that are being documented among men who have sex with men. So now let's get into prevention and care. So I organized a presentation basically following some of the models that we have and that we can use to develop interventions. Here is one of the models for the HIV Prevention Continuum. And basically everything that is in this model, we have. We can test people. If people test negative, one of the main challenges that we have is that sometimes we do nothing with people that test negative. Because most of the time we do testing because we're looking for the positives, right? So we can engage the positive in care. But we have a fantastic opportunity right after identifying a negative result. We can engage that person in services. We have multiple services. We've been discussing PrEP a lot, but we have other elements in the toolbox, including condom distribution, risk reduction, and counseling. That needs to be ongoing. We cannot just provide one service and assume that that's effective and that the person took it properly and will continue with whatever the practices are that we're recommending to reduce risk. And that is what adherence support means. We need to continuously assess the risk that that person or populations may have so we can improve the prevention services that we provide. But what's the challenge? Earlier today, we saw some challenges related to PrEP. So I'm going to start a little bit before PrEP. And by that, I mean other resources that we have from prevention. I'm going to share now some qualitative data that help us explaining some of the findings that we had from other more descriptive quantitative studies. So for example, a main challenge for a person to engage in care, in preventive care, is a self-perceived risk. And I'm sharing quotes. I'm not going to go through the quotes. I'm just leaving the quotes here so you know that I'm talking with evidence. That participants are sharing very low perceived risk, even though when in their narrative, they are at risk. Participants, some of the participants in our studies don't even know where to get tested. And for us, that might be a surprise because we are saturated with information related with HIV. But the average citizen in Puerto Rico is not talking about HIV. And that's problematic. So those at risk are not engaging in conversations about HIV necessarily, assuming that it's risky. Participants in our studies are sharing issues with confidentiality. People don't feel safe in certain environments. They feel that whatever information they share is going to be shared with others. Participants perceive challenges with access to services and linkages to services that they might need. That is not only related to HIV, but other health needs that they might have. Similarly, I think we believe that condoms are widely available and free. Well, some participants don't know about that. Try to ask an adolescent in your neighborhood if they know where to go to get free condoms. You'll be surprised to know that many don't know. We know because we are engaged in that conversation already. Most people aren't. And then there are some issues with the providers. People perceive that providers are not engaging in conversations. If they have access to providers, let's say that they have a primary care provider, the primary care provider is not talking about HIV, or are not engaging in conversations that are important, like their sexual practices, sexual activities, and partnerships. And let's get into PrEP, because so far I was just sharing information about other prevention practices and resources that we assume are available. But some studies conducted by Dolezal, and I believe Dr. Febo here was part of this team, early in 2015, they started asking about PrEP and PEP, and what they found, this is a sample of MSM here in San Juan, although a small sample, it was very early in the process. 15% had previous history of STI, 16%, only 60% have ever heard of PEP, 8% ever heard of PrEP, and they were less likely to use PEP or PrEP when compared to other men in Boston and Pittsburgh, that were the two other sites for this study. Further, in a study that we conducted at the University of Puerto Rico, among HIV positive MSM, only about 18% knew of PEP or PrEP. And these were HIV positive MSM. They are an important component in the conversation about PrEP because their potential sexual partners might benefit of PrEP or PEP. Getting further in the conversation about PrEP, again, more qualitative data from a more recent study. Some of our participants reported very low awareness of PrEP. They don't know. And they have heard something like prophylactics, but they don't really understand what PrEP means. Other participants were really limited in their knowledge. They have heard of it, they have looked for it, they're asking about it, but they don't understand what PrEP is. Participants clearly have shared in our studies unwillingness to use PrEP. Some people are not into using a medication to prevent an infection, period. Others question the recommendation of using PrEP and condoms. And they said, well, if I have to keep using condoms and condoms also protect me from HIV, why do I have to use PrEP? Extremely valid question, but we need to be ready to answer that kind of question. A very interesting conversation with this participant is kind of an example of conspiracy theory. You are not going to test on me a pill that I am not completely sure it will work, which basically is a good reference of the lack of knowledge and lack of understanding of PrEP. Nowadays, we have enough evidence to support the recommendation for people at increased risk for infection. So that's about HIV prevention. So I think we have many opportunities to intervene. Now let's take a look to the HIV Continuum of Care. And basically this is one model that we developed in our team, but is very consistent with other models. Basically identify an HIV positive individual, engage them in care, retain in care, adhere to antiretroviral therapy, and achieving viral suppression. That's consistent with the 90-90-90 model There was too many 90s there. But we also acknowledge that it's not only about the behaviors and the individuals, but structural factors, such as racism, homophobia, rejection, stigma, poverty, and violence. All these factors that are here are included in our model because based on our research, we know that these are covariates for disengagement in HIV care. And this is the most recent cascade of HIV care that I have access to. I believe it's from 2015. And I want to already share a recommendation for the conference. Next year, we can start with a good EPI presentation by the people who are doing the surveillance, who are running the surveillance system in Puerto Rico, and then we can all go with that. And that would, I think, accelerate the conversation. But anyway, this is the cascade of care in Puerto Rico. And I've heard from the Department of Health a lot of pride on the achievements. And when we compare this cascade to other cascades, including the national cascade in the United States, it's a little bit better. And yes, we should take pride in the good work. However, first let's question the fact that we're talking about a cascade. We should not be talking about a cascade. A cascade means that we are failing, right? So, in this cascade, nearly half of the participants are not achieving our goal of viral suppression. So it's good, but it's not that good. Half of the participants of our people living with HIV in Puerto Rico are not achieving viral suppression. And we know that not all the patients are going to get there. But almost 50% is not necessarily good news. In our studies in STI clinics here in Puerto Rico, what we found is a lot of co-occurrence of infections or co-infections with HIV. In a study that we published in 2012, we identified 50% of the MSM attended publicly funded clinics were diagnosed with HIV, but they also had history of other infections. Not surprising, and as previously shared, syphilis is the most prevalent of the other STIs. We have challenges in accessing HIV services in Puerto Rico. People are still reporting avoiding services because they are afraid of getting an HIV positive result. So even testing is still a problem. They have reported confidentiality concern and limited knowledge of where to go. And I know that for us who are providing service, that might seem like that's not possible. We have so many clinics. Not everybody knows what CLETS is or what ARARAT is. And we need to promote community-based, private, and publicly funded clinics so people actually know where to go. Access to HIV services are also challenged by not competent services for the populations that are at increased risk for infection. One of those populations are sexual and gender minorities. And here in Puerto Rico, we know that using NHBS data, that MSM, almost half in the first cycle were not ever being tested. That's going down, but from 50%, anywhere down it's promising, but it's not near the goal that we should have with a population that is an increased risk. Similarly, lesbian, gay, and bisexual participants in our studies have reported that they do not disclose their sexual orientation to healthcare providers. We have gone deeper on this one, and what we know is that LGBT populations actually share their sexual orientation and sexual practices more than physicians and healthcare providers asking them about sexual practices and sexual orientation or gender identity. So the main barrier usually is that healthcare providers say, that's too personal. I don't need to ask the sexual orientation of my participants. Well, the problem is that we don't perceive that as personal, and in fact, it's essential so you can provide proper services, including the assessments that are needed to identify either eligibility for certain prevention practices or HIV testing. And another challenge here is that we conducted an assessment with primary healthcare providers, and only 15% of the participants in that assessment, of nearly 500, only 15 have received training on LGBT health issues. That's very low. And we're not doing particularly good with those that need the most from us in healthcare services. Transgender populations are definitely having the worst part or experience in healthcare in Puerto Rico based on our study. We just published a paper in which we reported that 9 out of 10 self-identified trans individuals report having difficulties accessing and utilizing health services. That means that 1 out of 10 feel that can actually navigate the healthcare system here in Puerto Rico. I'm going to go very fast on this, but I think several presentations here have mentioned the work of Dr. Cynthia Perez and the population-based study that she conducted between 2008 and 2010. That is a very important study, but a few caveats. First, it was conducted only among adults between 21 and 65-year-old that were non-institutionalized in Puerto Rico. By non-institutionalized means that didn't include people in the correctional system, nor people who were in hospitals or other forms of assisted living. However, and the second thing is that it's kind of old now. It's at least 10 years old. But it's the only population-based data that we have. I think this is a call to my colleagues, friends, clinicians, and epidemiologists to come up with another study so we can have an updated version of this. Anyway, at the population level, we have discussed the prevalence of hepatitis C and HIV. But if we take a closer look to certain populations or risk factors, there are very interesting information here. For example, it was estimated that 7.3% of all the men who self-identify as men who have sex with men were positive to HIV. 76% of those with history of injecting drugs were positive to antibodies for hepatitis C, and history of incarceration was also another factor for very high rates of hepatitis C and HIV. With all this, one of the most recent studies that we conducted was an assessment of comorbidities in a sample of adults with HIV in Puerto Rico. And I have to publicly thank all the collaborators, clinics that supported this study. We reviewed 250 medical charts and collected data from the medical records to identify the most common comorbidities in a random sample of people with HIV in Puerto Rico. Very briefly, what we found, and Dr. Ivan Melendez will follow with a discussion on comorbidities, so hopefully this is a step for him to get deeper in the work that we need to do with comorbidities. Here in Puerto Rico, more than 95% of all the patients with HIV had at least one comorbidity. The most common comorbidities, and this is not controlling by any variables, were dyslipidemia, alcohol use, hypertension, cigarette smoking, and overweight. Yes, cigarette smoking and overweight are also risk factors, but were so prevalent that we decided to include it on this slide so we can identify different, not only factors, but also diagnoses common among HIV patients. All the comorbidities that we identify, here you have the distribution. We ran some analysis to identify what was happening by sex, and here we did not identify any transgender person in the sample, so we have 250 patients that are cis male or cis women. What we found out was that generally women have more comorbidities than men, and that was statistically significant. Men had an average of 3.5 comorbidities, while women have around 4. We ran some analysis of some of the risk factors and comorbidities, and by sex, the only factor that was different was alcohol abuse that was more frequently reported among men when compared to women. And by age, we divided the sample among those that were younger than 50 years and 50-year plus. That's consistent with the definition of aging that CDC is currently using. And we found out that the younger group reported alcohol abuse more frequently, and that dyslipidemia and hypertension was most frequently found in the records of patients that were 50 years older or more. Of course, this is very consistent with other distributions that we see in the general population in Puerto Rico. So, but again, this is a closer look to those that are affected by HIV. We capture common treatments among people with HIV here in Puerto Rico, and I hope that clinicians discuss a little bit more about why we recommend some often multivitamins for people with HIV in Puerto Rico, and then all the other therapies that are being currently used and were reported in the medical charts. Excuse me. We ran some analysis adjusting for age and sex, and what we found was that when compared to men, women were almost 6 times more likely to have a chronic comorbidity, were 7.8 times more likely to have osteoporosis, 3 times more likely to be obese, and 2 times more likely to have history of depression. When compared younger people to those that were 50 plus, those that were 50 years of age or more were nearly 3 times more likely to have been diagnosed with diabetes, dyslipidemia, and hypertension. And I have to agree, this is not rocket science, and for those of you who are clinicians, I think this is what you've seen in your practice. But surprisingly, it's the first time that we've done a study on comorbidities with people with HIV here in Puerto Rico. So now we have a reference with a very structured applying methodology. Hopefully, this will ignite other epidemiologists and public health scientists to do a deeper dig on this data or further studies. So what are we doing? I'm going to limit the discussion on what we're doing to the work that we are doing at the University of Puerto Rico and from George Washington University. I'm not saying that this is the only thing that we're doing, but in terms of interventionists, there are not too many of those among us, creating new interventions with the intention of having a validity and efficacy of those interventions. So I would share what we are doing and with the hopes of getting your suggestions and also help in disseminating. So in 2012, we started creating interventions for the population most at risk here in Puerto Rico. We created Contacto. Contacto is one face-to-face health education intervention with HIV positive MSM, and Contacto was proven to reduce depression, HIV stigma, and internalized homonegativity, and was proven to increase HIV disclosure, social support, and overall quality of life of HIV positive MSM here in Puerto Rico. This was the first intervention ever developed in Puerto Rico in Spanish for Puerto Ricans. 2012 is a problem. Now, because Contacto worked, we've been modeling that intervention to address the needs of other populations. Now, Dr. Suhail Malavé is leading Contactos, and Damian is the interventionist for that study, and she is adapting Contacto to a group-level intervention for young HIV-positive MSM here in Puerto Rico. It's a group-level intervention, and I think we are on the second of 4 groups that we are testing at this point. And we are recruiting. So if you see this campaign on social media or in your clinics and you have HIV positive MSM between the ages of, I want to say, can you remind me the ages?
16 to 29.
Gracias. So young MSM, 16 a 29. If you have those in your clinic, they're welcome to participate in our study. And another spin of that intervention is Contacta 2. And this is for HIV prevention. We're going to be testing this intervention as a health education intervention one-on-one, but based on motivational interviewing like the others, to increase engagement in HIV prevention services. So if you see, these are 3 interventions that are responding to all the findings that I've shared from the surveillance data, but also from our studies here in Puerto Rico. And we are very thrilled with the opportunity that we have now, as we have a collaboration with George Washington University and the Center for AIDS Research in DC to develop very specific collaborations here in Puerto Rico, and hopefully within the next month or so, we will confirm if we got funded to extend the capacity of the DC CFAR to conduct some research here in Puerto Rico. I'll be leading that effort with Dr. Suhail Malave and Dr. Melissa Marzan, and the sex team here at the University of Puerto Rico will be part of that. So if you're supportive of our work, cross your fingers, because this needs to happen. And finally, these are my final thoughts. This is after analyzing almost 10 years of doing HIV research here in Puerto Rico. First, we definitely need to do more on PrEP services and PrEP implementation science. I think we are already focusing in populations that need it the most, MSM. That's not enough. I actually think that we have to look at the needs of cis and transgender women and transgender population overall that we cannot even justify now because we are not counting, we are not describing transgender populations, particularly transgender men. People with problematic use of drugs cannot be left behind. I think we already have discussed a lot of evidence of what we can do. We need to stop stigma. It's getting old and we should be ashamed. The stigma that participants in our study continue to report is very similar to what was captured 30 years ago. And we need to help on that conversation. We might perceive that we have no stigma. We have to check that. And second, we need to talk about HIV and the factors that influence HIV risk outside of our comfort zones. Talk about HIV in your family, in school, in church, wherever you go. That's how we end and stop stigma. And I believe in mentorship. So we need to work with the next generation of healthcare providers and scientists. And the next generation has to be better than us. So they need our support. And with that, I want to thank the sex team, all the community partners. Many of you are here. I'm not disclosing all the different partners for different reasons, but gracias, muchas gracias. We are making a difference and we will end the epidemic.